I think it's worth to share a minute or two of my history. People know me as an academician, an inventor, an entrepreneur, but you never get anywhere without having great partners. So I had great partners at Sinai when I set up the brachytherapy program. I retired from clinical practice in 2012, moved to Colorado. Dave and I had like-minded interests in transperineal biopsy. He invited me down to the university. We spent some time working together, and then we developed with a team again, himself, Scott Lucia, Greg Baer, Wendy Pogue was part of that. And we're going to come out with a brand new needle, hopefully soon, that can take a 6-centimeter biopsy. And now fast forward to this. My son, Jonathan Stone's a neurosurgeon at the University of Rochester. He got together with his urology colleague, Ahmed Ghazi, and they started inventing new simulation tools to train physicians how to do surgical procedures, both residents and for new medical devices. And I got involved a year or two ago to help develop the urology line and the radiation oncology line of simulation tools, and that led to these ideas, which I think are going to be game changers for not only urology, but for all surgery. As my disclosure. So what is augmented reality? What is virtual reality? Well, augmented reality is you take the real world and you augment it to something additional, and that is in contrast to virtual reality. Virtual reality is basically an animation that you're looking at to give you instructions. And we're quite familiar with virtual reality in urology because it's been used to train in space OR procedures. It's been used to train in robotic procedures. Whereas augmented reality really hasn't gained an attraction. Extended reality is just a combination of augmented and virtual reality. So we all remember, especially the older surgeons, this paradigm that was first postulated by William Halsted, where we said, see a procedure, do a procedure, teach a procedure. And that's how simple it was in the old days, but that's no longer going to work today with all the new technology and the advances in minimally invasive surgery. And so our residents often learn surgical procedures by something called education by random opportunity. So if they happen to be in the OR during a particularly difficult case, they learn more. If they never get that experience, too bad. This has led to the advent of simulation models to improve surgical education. And there are all sorts of simulation models. I just mentioned my son and Dr. Ghazi, but many companies now make surgical models to practice surgery. The AUA has an extensive course on this. We are offering a course in April in Scottsdale where we have 12 stations to do hands-on training from biopsy to focal therapy to HIFU, et cetera. But COVID upended all of this because people couldn't get together for hands-on training. And just like Dan Petrolak said this morning, the iPhone became a great tool for telemedicine where you could talk to patients. How can we change so we can do all this training and observation remotely? So this whole idea really started about 10 or 15 years ago. One of the first systems that was developed was called the VPAR, where the surgeon is now, training surgeon's doing a case, and he or she's wearing a pair of these augmented reality glasses. That's converted into an animation. Then the trainer is at a remote site, can see the surgical field, and can draw on it. So at the most you're going to get, as you see here, is they're drawing on something, say, cut here or burn here or whatever. This has progressed, and now this is a system that's out, not currently available, where they arrange cameras in the OR, and you have the trainer down here watching the procedure. So there's the operative theater, and there's the endoscopic camera remotely being projected to the trainer, and they can draw on it real time. So they're drawing, can't see the arteries and veins below the fat, so they're drawing the location. So this addition is called telestration, so visual editing to assist the training surgeon to help with the procedure. Physicians at Duke develop a system for the military called the STAR platform. So just, you can see how recent this is, 2020. And this is not an actual limb. These are technicians working on a phantom, so it's a model. And the surgeon's here giving them instructions. Ideally, this is in the field, and this is how to do a fasciotomy. And they're, again, putting in the virtual instrument and the telestration to show them where to make the incision. The first attempt to do this with a wearable device was a paper written in 2018 where they had physicians in Africa wearing the Google glasses, and there was a camera here so you could see the operative field, and the physician at the remote site in the United States could observe the first-person view of the physician, which is very important, but all he could do at that point was, again, telestration. He could, just a burn victim, draw on the hand as to where the flaps were. The problem with this and other types of technology is companies or physicians are taking technology designed for other applications and trying to apply them to the medical field. They weren't specifically developed for the medical field. So how do you do this for the medical field? Well, you need to have an augmented reality headset. You do need a line of sight camera because you want the trainee's eyes to be your eyes when you're watching what they're doing. It has to be easy to set up. It has to have the annotation tools, and it needs to be wearable because you have to be able to walk around. So this is what it would look like. The lenses down here, the eyepieces, are see-through because the surgeon has to be able to see what's in front of them, and at the same time, you have to be able to project images into the see-through object. So there are miniature projectors in here that will project in a stereoscopic fashion those images. Now, how are you going to do this if you're going to communicate worldwide? So you need to have a web-based platform. And there's two types of training. One type of training is two-way training. So two-way training would exist if you're training somebody on a model and they're remote. So the trainer's wearing the headset, and in this example, there is an ultrasound probe in a phantom prostate connected to an ultrasound machine, and that's being beamed over to the student who's wearing a similar headset. The trainer or the proctor says, here's step one. He then turns over control to the student who has the exact same equipment, who then does step two. Proctor's now watching, and it's back and forth until they complete the training on the phantom. So that's two-way training. The other component of it is we're all familiar with Zoom. So when you're looking at a Zoom image, the images are tiled. They're next to each other. But if you're trying to observe somebody to do surgery, you can't look at two things at the same time. So what we did is we developed a software program where the images are stacked. And because I stacked the images, you can see the ultrasound image, which is now appearing in your eye, and you can see the hands below of the trainee who's performing a procedure. So I'm looking at the stacked image on my computer if I'm observing a trainee, and I can actually see what's happening when the needle's being put into the prostate and that his hands are in the right place. So let me show you a 30-second video of how this all works. This happened at the AUA. The trainer was Dr. Evan Kovac from Rutgers. Training for transperineal prostate biopsy using an access device combined with an augmented reality headset. Skills in transperineal prostate biopsy using an access system can be obtained by first practicing on a prostate phantom. These training sessions often take place in large hands-on workshops where individual instruction is limited. We introduced a remote training platform utilizing augmented reality where one-on-one training can be accomplished remotely.
All right, so you're going to take your right pinky and you're going to line up the precision point device by rotating the ultrasound until you see that line that you created. Yep. Right there should be it. And now you're going to gently push the precision point needle through the skin. You're going to feel a pop as it punctures the skin. And then you're going to feel that second pop when it clicks. And if you want, you could take a bite right there, and I would push the button with your right hand.
Push the button?
Yep. Take a good bite.
Push this one?
The pink button. Excellent. Excellent. Good job. You took a nice PZ bite there medially on the right side.
So fast forward now to another application. When we stopped doing open surgery, we needed to take our hands off our eyes because we needed to look at a monitor to do minimally invasive surgery. So, and we got really used to doing that. But can you imagine if now you can do surgery and you can look at your hands at the same time when you're doing an ultrasound or endoscopic procedure? So that's the whole idea of the medical heads-up display. So we ran a survey at the AUA. Here's a urologist wearing the heads-up display. He's got the probe in the rectum. He's doing transperineal biopsies. Now this requires a lot of hand-eye coordination because you've got to put the needle through the grid and you've got to continually look at your hands and back and forth to the monitor. Now you'll notice the urologist is not looking at the monitor because the monitor is in his eye, that image. That image is now projected on top of the phantom. So he's looking at the needle going into the prostate gland in this phantom, and he can see it simultaneously without taking his eyes off his hands. So we conducted a survey at the AUA. It's a usability survey to understand whether or not this is really going to be a useful tool. And you can see where the red is agree and strongly agree that 61% thought they didn't need to use the remote monitor. But more importantly, and this is something we'll need to test, almost 80% said this improved their hand-eye coordination because when they were doing a procedure, they did not need to take their eyes off their hands. And 100% said this is a valuable addition to being able to train people. So I'm going to show you a very short video, and then we'll be done, of how this all works. So this is a side view of the individual wearing the headset and looking at, this is a kidney phantom, and scanning it, and now someone's going to do a biopsy, and they're going to do, or not a biopsy, they're going to do a renal puncture access, and they're never going to take their eyes off their hands as they're putting the needle into the phantom. This composite view highlights the remote training advantages of the augmented reality headset. The image to the right is an external view of the clinician practicing the ultrasound-guided renal access procedure. The images on the upper left shows the ultrasound screen as it appears in the headset, and the lower image depicts the physician's hands while performing the procedure. After practice, the urologist has learned how to quickly access the collecting system, placing the needle through the renal parenchyma and just below the stone. This position will allow easy access to the ureter for the guide wire. Note the needle striking the adventitia of the collecting system without piercing it. The clinician forgot to secure the needle within the cannula and must lock it into place. This maneuver is nicely captured by the webcam and reinforces the importance of having a line-of-sight view for teaching. In conclusion, two-way training on phantoms is feasible using an augmented reality headset along with software that stacks the images and provides annotation capabilities. One-way clinical training where the proctor remotely observes the trainee who wears a headset is also feasible. The XR headset, which projects the monitor image to the clinician's eyes and allows him to watch his hands during the procedure, warrants further investigation. Thank you very much, David.